Okay. So I'm going to go a little bit into the neuroscience. We're going to keep it pretty light. Does this work? Pretty light. Nothing that I think is going to be over anyone's head, but prepare for some neuroscience. I'm from Karuna. I'm the chief scientist of Karuna, and we've got Lincoln, the CEO and essentially CTO, is right back there, and he's going to be demoing right after this presentation. And we use immersive virtual reality. Another word for that is embodied, and we're going to get into that in a minute, to treat chronic pain in virtual reality. So, immersive virtual reality software to address chronic pain. So the kind of pain that we're treating is what we call chronic central pain. Central pain means that it originates in the central nervous system, the brain and the spinal cord. So we're not talking about pain that's immediately due to a very recent injury, but pain that now exists in the brain. So there are many potential causes. Sometimes this is pain that endures after an injury heals. It's persistent, it's made worse by movement, by touch, and by psychosocial factors. So stress can worsen this kind of central pain. Relationship problems can worsen this kind of central pain. And then we would want to understand what goes on in the brain by understanding what the homunculus is. You may have seen a picture of the homunculus, and if not, I'm going to show you one in a minute. It is the little representation of your body that exists inside the brain. We have two homunculi, a sensory homunculus and a motor homunculus. We're going to talk about both, but we'll start out with the sensory homunculus. So essentially what we may find is that in chronic pain, the homunculus, which is the representation of the body and the brain, may become abnormal. So if I have pain in my knee, chronic pain, it may happen that my brain starts to interpret signals from regions next to my knee, maybe my thigh, maybe my leg, my calf, as signaling from that knee, because it overrepresents, it overweighs the importance of that painful region. And this reduces a patient's pain-free range of motion, because the brain interprets, this is that homunculus, interprets that region that has pain as bigger and more loud than other parts of the body. So on the left here, we have a healthy homunculus, and on the right, we have the most extreme example of homuncular change that's associated with pain, and that is phantom limb pain. Many people have heard of phantom limb pain. It's something that occurs after there's an amputation. Let's say you've lost your hand, and the brain actually interprets pain that originates in that hand, even though the hand no longer exists. This is a pretty extreme example of homuncular changes in the brain. As we can see here, the brain sort of interprets signals from the shoulder, maybe even from the eye and nose, because they're adjacent to where the hand would be, as painful. So, phantom limb pain in the 1990s was treated by a guy named Ramachandran using mirrors. This is the origination of the mirror visual feedback paradigm. The way it works is, we have a little representation here. This patient's amputated limb is hidden behind a mirror, and his healthy limb is reflected in that mirror. Now, the patient can undergo various exercises, maybe this is a nicer picture, can undergo various exercises that help him see a representation of what he's been hoping to see. For example, if he's had a feeling of a clenched fist, he really feels like his fingernails have been digging into his hand for years and he can get no relief, now he can unfurl his fingers. He can shake out that hand, and having that visual representation starts to relieve those painful symptoms that he experiences in a limb that's no longer there. So here's the bit of the neuroscience. Here's why we think that this actually works. First of all, the visual system in the brain, the human brain at least, is the most dominant system. It is by far our most developed sense, more than smell, more than even touch. So very often, the brain will use visual input to override other sensory input. This is why something like mirror visual feedback really makes a difference. It's the most dominant system in the brain. Now, another mechanism for why we think this might work is that we're rebalancing the afferent and the efferent discrepancy. What is that? The brain sending out signals through the motor system is the efferent system. The brain receiving back signals through the afferent sensory system, that's afferent. When we have a healthy hand, we have a balance between the afferent and the efferent. But when we have phantom limb pain, the signal that the brain sends out, which says, unclench the fist, and the signal it's getting in, both in terms of the pain that it feels and in terms of the visual input that's saying, but nothing's happening, they don't match anymore. So by giving the brain the visual input that it expects, we're starting to rebalance the afferent and the efferent, and thereby relieve that discrepancy and relieve some symptoms. This is actually not that different from seasickness, where what happens is the brain sends out a motor signal that says, I'm standing still, but the visual input is, no, there's movement, and this causes symptomology. So this is another way to understand what's happening there with that unbalanced input and output system. We think, and this is speculative, that there's mirror neuron involvement. For those who don't know about mirror neurons, that is the system in the brain that is used to experience empathy. So if I see Feng Wei rub his nose, maybe my system, my mirror neurons start to feel, I'm rubbing my nose too. If I see someone drink a Coke, my Coke mirror neuron network may start firing. And we hear from many physical therapists that we work with at Karuna that when they have patients with chronic pain, they may often say, when I see my wife, for example, move her shoulder, I start to feel it too. So this is speculative, but it has been written about in papers. People do think that there might be mirror neuron involvement in mirror therapy. Lastly, we do know that there's some cortical sensory reprogramming that happens with mirror visual feedback. I'm not going to get into the details with this crowd, but to tell you a little bit about what's been found, there's activation in spatial attention. There's activation in the self-awareness centers. In the primary somatosensory cortex, contralateral to the affected limb. Remember from way back when in biology class that what happens on the right side of your body is actually felt on the left side of the body. So we see that activation is exactly what we would expect if there was a real hand moving. We got that activation happening in the brain. And there's also activation in the visual memory centers of the brain, which is interesting because it helps us understand that when people undergo mirror visual feedback, it triggers their old visual memories of what happened. It kind of helps them remember, there was a time where I remember reaching, throwing a basketball in a healthy manner. There was a time I remember what it looked like to bend over and touch my toes before I had chronic lower back pain. So at Karuna, we got very excited about mirror visual feedback, but then we did a whole lot of research and found that there's a more comprehensive system called graded motor imagery, which is a more systematic manner of reintroducing the brain to the movement that it's been afraid to produce. There's a whole lot of avoidance that happens with chronic pain. And this graded motor imagery is a method of addressing it in a systematic way for chronic pain patients who are avoidant of movement. The very first stage is a laterality stage. We actually find that when people have chronic enough pain, they become somewhat blinded to even recognition of body parts. If I have a tennis elbow in my right hand, or my right elbow, as it were, I will be slower than a person without pain at recognizing whether I'm looking at a right arm or a left arm. So the first stage of graded motor imagery is actually to train people to become attuned to those body parts again, because their brain has become kind of avoidant of paying attention to those body parts. The second stage is used in sports therapy a lot. Motor imagery. You're sitting there, you're not moving at all, but you undergo the process of imagining what it feels like to make that shot. Both in a visual sense, what would it look like if I threw a basketball, and in the mirror, in the motor memory sense, in the muscle memory. What does it feel like to throw a basketball? We think that stage of things activates the premotor and the primary motor centers of the brain. Lastly is that mirror visual feedback that we just spent a few minutes coming to understand. And that we think is sensory motor as well as visual activation. So there's been some research on graded motor imagery, and it's found that there's a pretty robust effect size, that on its own, mirror visual feedback is effective, and graded motor imagery is effective as well. However, the ordering of graded motor imagery is actually really important. It is important to do laterality followed by motor imagery, followed by mirror therapy. On their own, the laterality component and the motor imagery component are not really effective. And that is, it supports that hypothesis that we're introducing the brain to movement in a systematic manner for patients who aren't ready to go straight for the mirror therapy quite yet. So that sort of brings us to the question, why virtual reality, given that GMI, graded motor imagery, works pretty well outside of virtual reality? And our answer to that is embodiment. So what is embodiment? There's a very cool rubber hand illusion. If I had a YouTube clip, it would be enjoyable for you guys to watch, but I can explain it to you. So I keep cutting in and out. Should I try another one? All right.
Just press that again. Yeah, just try now. Oh.
Okay. I'll keep trying here.
It's very, you have to hold it close.
Yeah, totally close. All right. So as we can see, what's happening with this subject is that his left arm is hidden from his view. He is looking down instead. It's behind some barrier. He's looking down instead at a not even particularly realistic rubber hand. And the experimenter is stroking his hand and his rubber hand in unison. So he'll stroke the thumbs at the same time, the forefinger at the same time. He'll make a circle on the palm. And within a few minutes, up to about 70% of people, not everybody, but the subject will become identified with that rubber hand. So that the experimenter no longer needs to touch his real hand in order for him to feel sensation in that rubber hand when he looks at it. In fact, if you ask him to close his eyes and point to where his hand is, he will point to the rubber hand. So this happens pretty consistently, and it's an illustration of the principle that we think our brain is identified to our body, but the brain is actually fairly flexible in terms of what it's willing to be identified with. And where's my clicker? And we bring this into virtual reality with all sorts of interesting possibilities opening up. Lincoln likes to say that he can get someone embodied to an octopus, but it's true. We can actually have someone embody a healthy avatar in virtual reality and apply that principle that the visual input is the most dominant input into the brain on a whole body. So the implications here is that we no longer need sightedness. We no longer need to have a body part that is reflected in a mirror in order to apply the principle. We can now address pain below the neck anywhere. We can't yet address head pain because at this point in time, we can't be embodied and look at our head at the same time. So if you're inside a body at this point, we still feel like we're inside the head. But this does eliminate the need for sightedness. In fact, double amputees are also possible. I could use my left leg to move my right arm in virtual reality. There's no reason to be restricted at all. Another reason that VR is actually really, really interesting in this respect is that we can manipulate physical reality, in virtual reality, in a way that we can't in real reality. For example, if we have a patient who's really reluctant to move, we can show them movement that they're not yet ready to perform. It makes the motor imagery component that we talked about, that sort of closing your eyes and imagining throwing the basketball, we can now embody you into this avatar and have you watch it happen. And people really report, wow, I feel like my limbs are moving. And lastly, that first-person perspective really is very immersive. So looking in the mirror is one thing, and it's cool, and it seems to work, but looking down and seeing your own arm move out of your body, out of your chest, is even more powerful. So we thought it would be more powerful, and then we found this study that actually made a direct comparison in fMRI, that is, in the brain-imaged activity in the brain. And they found that the patients in both conditions felt relief, equally strongly even, and they felt that the mirror limb was actually moving. But what they found in the fMRI was that activation for the virtual condition was stronger in the contralateral sensory motor activation in that virtual condition. And given that this was a fairly short study, we think that this is really promising, that if people were to undergo longer courses of therapy in virtual reality, there's a very good chance that this could be a much more profound way of going about pain relief and changes in the brain. This is also consistent with our hypothesis that first-person virtual reality being really immersive is important. It's a powerful experience. So I kind of want to talk about what the implications are. Karuna is a very young company. We formed in November, we only incorporated in March, so we can't show you robust clinical data, but we have some real reasons to believe that we can address chronic pain below the neck in a meaningful way. So let's talk about chronic lower back pain. What do we know about chronic lower back pain? So first, remember that homunculus that I showed you, that little body that exists in the brain or represents what we feel? What we know about chronic lower back pain is that the representation of the back starts to expand into the leg, receiving disproportionate weight. This is what we already know. The brain interprets signals that aren't even related to the lower back as painful signals coming from the lower back. We know that the effect is present for people who report emotional distress. So we know there's that psychological component that our therapy addresses. We know that there's altered cortical response to stimulus, and especially stimulus that's not noxious. So if I have lower back pain and I happen to sort of brush against this table, I may even experience that as painful, even though objectively speaking, it's really not noxious stimulus for my back. And we know that there's reduced representation in the motor cortex. So the motor homunculus, the one that corresponds to how much we're willing to move, reduced. Chronic lower back pain patients are much less willing to move. So for example, the way I like to explain this is if you have a disc rupture, you really may not be able to reach down and touch your toes. It's possible that that's going to be beyond your means. But that reduced representation in motor cortex means you may not even be willing to bend over 10 degrees to reach something across the table. And really, in reality, you may have as much range of motion as 40 to 50 degrees if we help you have a more realistic representation in your brain. What the implications are is that with our graded motor imagery in virtual reality in embodied form, we think we are providing these new hopes for central chronic pain conditions anywhere below the neck, including lower back. It's literally not been possible to do this until embodied immersive virtual reality, which has really only been the last couple of years with handheld controllers, with leap motion cameras that look at your lens, with body tracking technology that's become much more affordable. So this is really new. It's a very exciting new prospect. It's crucial to incorporate psychoeducation because there's such a strong component of avoidance, of belief, of people not understanding what their pain is and thinking that any sort of signaling of pain represents a real danger to the body, whereas that's not really true, and we're helping them recalibrate to what is actually possible range of motion for them. So we built a comprehensive biopsychosocial approach that I'm happy to talk about. There's some meditation components. There is symptom tracking, but of course, just like Jonathan said, I'm here to mostly talk about the VR, so I'm talking about the VR. And that's us. We are in several hospitals at this point, running several studies, and we'd be happy to talk about our progress in the Q&A and afterwards. Thank you.